when I heard it was triple negative, I was like, oh God, what's that? Because again, there's so many different types of breast cancer, and it's a mind fog. You get told you've got cancer and all you hear is blah, blah, blah. It's like tunnel vision. You can't take anything in. You're thrown lots of information. And I sort of looked up and said, oh, okay, so it's an aggressive type. I know there's a small percentage of breast cancers that's triple negative. And I know that it's very changeable. And yeah, it's a hard one to sort of, it's a difficult one.
Thank you and welcome to Innovating Healthcare as we anticipate World Cancer Day in February 2023. I'm pleased to be joined by experts in the field of breast cancer today and its role in that momentous day when it comes. Breast cancer is the commonest cancer in women and not unknown in men, and we may come to that later on as well. But our focus at the moment is on recovery around the world from the COVID pandemic. And part of that recovery is recovering cancer services to be much more adept and accessible as we deal with enormous backlogs, not just in the United Kingdom, but worldwide. So my name is Mike Bewick, and I am the lead for this particular episode. And I hope that you're all going to enjoy it and contribute when we publish this. So I'm going to go to my guests now, and I'm going to start with Victoria Harmer, a consultant nurse at Imperial College Healthcare in breast cancer. Would you just introduce yourself, please?
Yes, hello, I'm Dr. Vicky Harmer, and I'm consultant nurse in breast care at Imperial College Healthcare London. So head up the nursing for the screening and the symptomatic breast services.
Yeah. Julia Levy.
Hello, I'm Julia Levy. I am the principal focused on oncology real-world solutions for IQVIA, which is a company which focuses on the delivery of value and insights from health data.
And of course, health data is becoming increasingly important in how we both diagnose and then follow up a lot of patients with these conditions. So it's good that you're on the call. Thank you very much. And Charlotte, most importantly, you're going to tell us a little bit about the experiences within this cancer pathway.
Yeah, hi, I'm Charlotte. I'm a 45-year-old mum of two, and I got diagnosed in September 2021 with triple negative breast cancer. So I've gone the full hog with chemo, surgery and radiotherapy, and I'm still currently going under oral chemotherapy just to try and mop up the last bit. So it's been a long journey, but I'm here, which is the main thing.
Well, it's good to see you looking so well, and I'm very pleased that your treatment's going so well. So we'll hear more about that later on, I'm sure. I'm going to start with Julia, and perhaps you could, and please, I'll follow this up with Victoria. Could you just give us an indication of the scale of the problem in terms of breast cancer, and where treatments have got us these days, and I suppose some of the reassurances around knowing that those treatments are available. So, Julie, perhaps you could give us some of the background in sort of epidemiology.
Based on some of the more recent stats that are available, there's over 56,000 people a year diagnosed with breast cancer, which makes it the most common cancer that affects women and one of the most common cancers overall. I think one of the key headline messages is that there has been a tremendous set of developments in the care of people with breast cancer. So now we're looking at 96% of people surviving the first year, but then over 75% of people surviving to 10 years, which is really the gold standard. It's the long-term survival that we're working towards. And that has been driven by a combination of things. I think the actual development of treatments themselves, there's been huge innovation in that, from a chemotherapy, oral therapies. Just Charlotte is the wonderful expression of that, and on all the different interventions she's had, but also things like surgery and radiotherapy. The clinical community's got much better at understanding when and how to use those interventions, how to use them appropriately. I think it's become a much more targeted experience in terms of the clinical journey and the patient journey, or overall with improving outcomes.
And Victoria, I'd like you to maybe start about the beginning of this journey for a patient, which is diagnostics and also prevention and screening aspects of this. Perhaps you could indicate some of what's happening in that, and then we'll go on to the management side.
Yes, at Imperial, we diagnose probably about 50% of the breast cancers that we see at the trust through screening and 50% through symptomatic. Of course, we have those two routes. So the routine screening, or if people feel lumps and bumps, go to their GP and then are sent here. And absolutely, it's 1 in 7 women will get breast cancer at one point or other. Now, of course, the lion's share of those women are postmenopausal. So Charlotte will, other issues. But absolutely, as Julia said, I think the importance, and what we're doing now very much so, is we're sharpening our tools. We're personalizing treatment plans to the specific person and the cancer that they had also, so that we're really bolstering, really, as I say, sharpening up all of the tools in our armory and boxing more clever.
Mm-hmm. In terms of the screening, are there any changes to the age groups that are coming in with that?
So, as a standard, it was 50 to 70, and some areas were trying the age extension trial. So it meant that people would have their first screening mammogram between 47 to 50, and then one last one at the end between 70 to 73. And of course, pre-pandemic, there was the capacity also to have people who were older who requested to be screened additionally if they were over the top of the age bracket, if you like. So we do different things, clearly, for women who have got a strong family history or any of the genetic mutations. Then we do all sorts of other clever yearly stuff. But I suppose on the whole, it's between 50 and 70, and it's every 3 years we invite people to the screening unit to have a mammogram.
I'll come back to the genetics of this later, if you don't mind, but it's a big subject. But can you just tell, for people who perhaps don't know, why you don't screen younger women, premenopausal women generally?
We don't normally screen younger people because breast cancer, about 80% of breast cancer is found in the postmenopausal woman. I suppose the UK menopause is 50, 51. And so that would be a good start, I think. It all started from the Forest report way back in, I think it was 1988. The other thing is that we use mammography as our screening tool. Now, mammograms are x-rays of the breast, and so they show up black, white, and every shade of grey, and that's how they're interpreted. Younger women have more dense breasts, so less shows up in mammograms. It would just purely show up all white, like a snowstorm sort of thing. And so mammograms aren't useful in the younger cohort of women. So that, partnered with the risk factors, the two main being a woman and increasing age, has made us focus our efforts to 50 to 70-year-olds every 3 years in the UK on the NHS.
That's good. You're giving me a memory recharge here. I was working in medical oncology in Dundee just before that Forest report, but we worked with the Forest group on the tamoxifen trials and the initial ones there. And it's fascinating to see how this has evolved since, although I'm not directly involved with it anymore. So coming to a sort of patient perspective here, Charlotte, how was yours picked up? Was that because your self-examination? Was it something else that happened?
Yeah, so I found a lump one morning, thought, right, okay, let's ring the GP. Luckily, my GP was great. He thought it was just a cyst, but said, look, we'll send you on to the breast clinic anyway, just to be checked. And I was thinking, okay, it's just a cyst, it's nothing to worry about. Went to see the breast clinic, and again, they thought it was just a cyst, but had the mammograms. And as Vicky said, it's so hard I didn't realise, I was so naive with all of this. I didn't realise how hard it is actually to detect breast cancer when you are younger. And so they had to do a series of mammograms that day. I ended up having, ultrasounds and biopsies. And then I got told, yeah, it's triple negative breast cancer. and then I went down that journey. So it all happened quite quickly within about 2 weeks, 2 to 3 weeks. So I was really fortunate that I had a great GP that sort of pushed that.
That's, as a former GP, that's very nice to hear.
Yeah.
It's quite good that you've had that experience. Do you want to just try and explain what triple negative means to people?
Yeah, so, you know, when I heard it was triple negative, I was like, oh God, what's that? Because again, there's so many different types of breast cancer, and it's a mind fog. You know, you get told you've got cancer and all you hear is blah, blah, blah. You know, it's like tunnel vision. You can't take anything in. You're thrown lots of information. And I sort of looked up and said, oh, okay, so it's an aggressive type. You know, there's only, I know there's a small percentage of breast cancers that's triple negative. And I know that it's very changeable, and yeah, it's a hard one to sort of, it's a difficult one. So that was a bit of a shock because I haven't got any breast cancer in the family. I got tested for the BRCA gene, that all came back negative, which is fantastic for my family. So for me, it was a real shock. And I said, there's a lot of information, especially when you're a patient, because you're not coming from like a medical background. So suddenly you're thrown into this world of this new vocabulary and trying to work everything out whilst trying to deal with everything mentally and emotionally what you're going through. So yeah, it's been a steep learning curve.
Okay. So what sort of support did you get when you had this diagnosis? Who looked after you, I guess?
Yeah, I was really, really lucky I'm part of the Maidstone and Tunbridge Wells Trust. Their team is fantastic. And I felt really lucky. I felt I could trust them completely. I kept saying to everyone, I'm in the best hands. They're going to get me through this. And they were phenomenal. The whole team were great. Leading up to my mastectomy. So I had all my chemotherapy, then I had a single mastectomy, and things changed slightly then. I feel like the aftercare has been a little bit tricky, but that's a whole nother subject. But then I've been really lucky that I've had help, you know, from like the Pink Ribbon Foundation have been massive for me. They're obviously a charity, and I got so much support from them and advice and information, because it's really hard to know where to go. You know, I found ringing into the hospital, I didn't know who to ring. I suddenly had like a whole load of different numbers for different departments, and I didn't know who I should be going to. It's a real minefield. Then you get voicemail, so you're leaving messages that can take a few days for people to get back to you. And I understand that the strain on the NHS and how, you know, they've got so many patients to look after. But when you're worried about what you're going through and how you're feeling, that can be quite difficult.
And maybe a difficult question. What did you tell your children?
That was really difficult. I was really honest, really, really honest. I think literally, God, was it 2 weeks before I found my lump that my son's best friend's father passed away from cancer. So it's very raw in the family. And for him, his only experience with cancer was death. You know, Alex is my age, so it was very, very raw. But we were just really honest. We got all the facts first, found out what my treatment plan was going to be. And then we sat them down and said, right, this is how it's going to be. You know, I'm a fighter, I'm positive, there's no way am I going to let this get the better of me. But I promised to be open with them the whole way. I know I'm friends with a lot of different cancer patients, and they try to shield their children from some of the information, which I do fully understand. But for me, I think my children really appreciated the honesty. And I used to go to like my scans and take photos of all the different machines and everything for my son, so he could see what mummy was going through. And I filmed when I got my first EC, because I didn't know what chemo was going to be like. So I filmed that so that I could show them and explain what happened, you know, and how I felt with that. So, but that was probably the hardest conversation ever, and I wouldn't wish it on anyone. It's very hard.
You obviously did the right thing. I'm going to come back to you in a few minutes. Julie, we heard there about various gene combinations, BRCA and BRCA1 and BRCA2. What's going on in terms of early interventions and screening for generally women who are predisposed?
I think it goes hand in hand. First of all, we now recognise that there is no such thing as just breast cancer, and the importance of screening to really understand not just the genetic profile of the tumour itself, but of the individual. That's where Charlotte was talking about BRCA. That's an inherited chromosome gene which has a big impact in terms of the treatment options and potential prognosis for the disease. But we're learning more and more about different mutations and the impact of those different mutations. And more importantly, we're then developing treatments to help, which will be targeted to those mutations. So now with the appropriate genetic and genomic profiling, we can understand which treatments will be effective or have a higher chance of being effective, and also those which are having a lesser chance of being effective, which means that patients don't need to go through treatments that may not actually have a good outcome for them and be helpful. So huge amounts of innovation, huge amounts of insights into the right therapies and development of the right therapies.
So in summary, we've got a genetic profile that might help with early diagnosis if you know in your family you carry that gene. And secondly, if you do carry it, it gives as a hope for some more precision medicine around how you'll intervene. And that must save a lot of morbidity, I guess.
Yeah, it saves definitely the morbidity. It definitely just basically gives better outcomes and better clarity for the clinical community and for the patient as well.
Good, good. I'm going to go back to our clinician now, Victoria, and just say, you've heard a lot from the feedback from a patient's experience, a scientist's experience behind all this. Practically, when you get someone working with you who's recently been diagnosed, take us through what you say to them and what sort of treatment options are around. I know this might be enormous because there's various types of breast cancer, but give us an overview if you could.
Yeah, so thank you. And absolutely, when someone is diagnosed with breast cancer, it's traditionally and usually, I suppose, a surgeon that would give the news, and there is likely to be a nurse specialist in the room. And that would be the key point to then afterwards take the person who's newly diagnosed to another room to talk through, to translate perhaps what was said and what the next steps will be. We kind of, it's very personalized to what that person will be experiencing, what the offer is, what we know, and also to understand where they are at that moment. They may just have heard enough and want to go home, or slightly unpack it and form a slight crib about where they will be next. Treatment for breast cancer mainly would be surgery first, and then adding on potentially chemotherapy, radiotherapy, these targeted treatments that we're getting, and then potentially these additional, now we're getting this new class of drugs, these oral treatments. However, certainly, as Charlotte has alluded to, for triple negative breast cancer, we would probably give the chemotherapy first because we know it works really well with tumours of those characteristics, and then do surgery later. Also, the genetic testing is more likely, I suppose, to occur with people with triple negative breast cancer because, and so we would have time while people were having chemotherapy to test them genetically, so that then we could pitch, if there was the genetic mutation present, we could pitch the surgery at the right time, and so that would potentially be prophylactic surgery to the other side, etc. Plus, of course, reconstructions. There's huge, treatment is so much more sophisticated. We're incredibly lucky. I think the scary thing is the numbers. Breast cancer is incredibly common, 1 in 7 women, but because of the huge numbers that we've got great numbers in clinical trials. So really robust trial outcomes which show benefits of treatment, which we can then offer to patients as we go along. There's huge issues which we could talk about: genetics, as I say, fertility, have conversations, fertility when someone is about to start chemotherapy, because that can be potential side effect to bring menopause earlier, if not immediately. And also, yes, as I say, reconstruction options to reconstruct the breast, rebuild it if they are requiring a mastectomy for treatment. As Charlotte said, also, or your question to Charlotte mentioned, it's also work issues, telling the children, the person, it's the medical treatment for that person, but of course, most importantly, it's dovetailing our support to the other parts, doing our needs assessment. Are they breadwinner for the family? Is work important? Do they have dependents, or do they have older family who can look after them? So there's all sorts of things, and nothing is in a state of it's all in a fluid state. So if someone's okay one time you see them, at the next follow-up, again, it's checking in, are you okay? And how are you really? Those sort of open questions.
I think you mentioned some of the contributions that are there that help people as we move to a very successful treatments available and high survivorship. This sort of survivalism as well, and people who are looking at those long-term consequences. Do you follow your patients up for long, or do you return them back to their their GPs and other services? I remember meeting a district nurse in Essex who was doing work on survivorship and going out and seeing families where people actually had long-term remissions from such diseases.
We're hospital based, of course. You've hit the nail on the head there with straddling community and hospital boundaries, and then also adding in the third sector, the charities, and getting the wonderful resources, using those, which we're very well represented for breast cancer. But absolutely, it's straddling the patient journey. Someone mentioned that the nurse specialist was akin to a patient sat-nav, because we're there at diagnosis and then through each of the treatments, throughout of, the whole modality of treatment, all of the modalities throughout the trajectory of treatment, and then afterwards. So we would, at the end of hospital-based treatment, then have an assessment by a nurse, go through everything, make sure someone's new normal, I guess. It's normalization, isn't it? Sort of releasing someone back into the community, checking that they've got everything that they need, checking that they know any red flag symptoms, and then we would invite them to a mammogram every year for the next 5 years. But we would traditionally not see people in follow-up, which we used to do. So absolutely. So patients then would hopefully be armed with the information to contact us if they had any red flag symptoms, were worried about recurrences or other mischief.
Yeah. So there's a good backup is what you're saying here, and it comes from various sources: community-based nurses, the third sector charities, and also your own hotlines and ability to sort of keep in touch with people when they've got difficulties. You also mentioned something else which I think is critical, and that is access to research. And I'm just going to come finally, Charlotte, to talk about the role of research at the moment. And the UK has gone through a difficult patch in getting patients into clinical trials again, post-COVID. Is this an area where we are very good and we do get a lot of patients into clinical trials?
Yeah, my experience, I'm actually signing up to do the CESS trial for triple negative breast cancer, because I feel that we need to. I feel that for me, I just want to do my part. I've gone through, it's been a horrendous 18 months. And if I can prevent someone else having to go through this, then I'll do everything I can for that. And I said, my care team at Maidstone and Tunbridge Wells have been phenomenal with the sort of support and advice they've given me with this. And also for me, it's another way that I can keep getting monitored for selfish reasons, that if I'm on a trial, then I'm gonna get monitored more closely, because they have to make sure that everything's going to plan. So for me, it was a no-brainer. I'm still on capecitabine oral chemo, so I've got 2 more rounds left, and then hopefully I'll be done with that, and then I can crack on with the trial. But I think it's really important, and I think some patients that I've spoken to are like, oh no, I don't want to do any more, I don't want any more medication, which I get. We've gone through enough and our bodies have been, battered. But I just think we need to do everything we can to help with research and stop this happening for other women and men, as you said. So I think it's key.
Good. And Julia, in terms of nationally, how are we doing, and are we getting people into trials?
I think trials is one part of the picture. I think another really important component of this is understanding real world data. So not just what's happening in the very structured environment of clinical trials, which is clearly critical to help determine efficacy and safety, but then we can glean so much in the way of insight and understanding when we look at what's happening in the day-to-day practice. So Charlotte, before you went into a clinical trial, what your journey has been up till now, what your experiences have been of the actual treatments themselves, also your experience. So the patient-reported experience, patient-reported outcomes, which is so important, both to ensuring that quality of life is optimized, but also it can provide early warning signals of things like potential side effects that can then be managed with the kind of interventions, the holistic approach that Vicky was talking about. So I think we need to look at both the real world and at the clinical trial setting. And that's where the UK has the potential to really be world leading, which is harnessing the kinds of insights which are possible using the patient records from the NHS. And that has to be done with patients. It has to be done appropriately. It has to be done ethically. And there are lots of safeguards in place and ways of working in place to ensure that happens. But I think it is one of the places where the UK really can be world leading.
Okay. And finally, each of you, we publicise this across a wide variety of stakeholders, but a lot of people who will look at this programme will come from the world of politics and policymakers. So I just want you to briefly say what your message would be to them around breast cancer. We'll start with the clinician first, then go to the scientist, and then go to the patient. So if you could start us off, Victoria.
Thanks. I would say listen to the clinicians, also listen to those of us who day-to-day business is being involved in providing clinical care, and
what would you like them to hear from you as a clinician? What are the areas that need improved?
Well, it's very easy to say we need more workforce, because that's sort of the answer to everything, and that's something that can't happen for us all. You know, yes, lovely to have more nurses, to have more clinic rooms, you know, the environment as well as the people and the equipment, the kit. That is probably unrealistic, although it would be amazing. So I think to keep the listening ear, to keep us, you know, in conversation. We just need the resources. We need the resources. We need to be. We need to understand that we have their support.
Okay, that's fine. Thank you, Julia.
I think first and foremost, to maintain this holistic, person-centered view of care is at the foundation of all of what we're talking about. And then with the lens through which we look at the world, I would say harness the power of data with that mindset, because data can inform clinicians' ways of working. We need the clinicians, we need the clinical community to actually provide that data in a way that can be used. Patients are at the center of determining what the appropriate ways of using that data are, but also can play a very active role in contributing that data. So I think underpinning all of that, if we have those good insights, that can then help with what Vicky was just talking about in terms of making a clear case for where those resources are best placed, what the gaps are from where today's reality is to what an optimal scenario would be. So that's the opportunity.
And Charlotte.
I think I would say, I think maybe take the pressure off GPs in one respect. I know so many women that have gone to their GPs when they've had symptoms and sort of been dismissed slightly. So I think if there's like, I don't know, a hotline or somewhere that people can ring if they've got any breast cancer, you know, if they feel they've got a symptom, and they can be referred that way. And I also think, again, there's so much pressure on the NHS, and as a patient, you go through, you know, your body's going through a lot, but also your brain, your mind, your head as well. And the whole emotional side of it is so difficult. And I think we need help with that. And again, as I said, the likes of charities, funding for charities like the Pink Ribbon that have been so honestly, so supportive for me and been able to give me services that can help me with sort of counselling and wig advice and things like that, I think is so, so important.